of monitoring heparin. As clinical hematologists, we never ever use ACT, but in this particular situation, it serves its purpose. Of course, APTT can be used in monitoring heparin, but the kind of dosage of heparin that we use, there is apparently a plateau. Once the dose exceeds a certain level, the APTT doesn't respond in a linear way. So APTT loses its importance after a certain dose of heparin. So ACT is still very important. But when you look at the disadvantage of using ACT is dependent on several other factors, like depletion of coagulation factors, thrombocytopenia, hypothermia, etc. can affect ACT. So ACT by itself may not be absolutely accurate in telling you how the patient is anticoagulated. So there were some experts telling that you have to use one or two additional methods to tell you that your ACT is working. So one is an anti-10A level, which doesn't depend on several of these coagulation factors which can be depleted. Your patient on ECMO may be having DIC, sepsis, etc. And there are several competing deficiencies which will affect the ACT. So one thing you can use is an anti-10A level, which does not get affected by that. So what you could do is when you're doing ACT regularly, you could do a daily anti-10A level. You should definitely alert the lab that you're doing an anti-10A level for this purpose, so that